My name is Carolyn Hart. I'm with JSI's Washington office, and it's a great pleasure to welcome you here this morning to this event, which we are privileged to co-host with the Chlorhexidine Working Group. We are interested in hearing what the panelists have to say to us from the country perspectives. I think we all have an appreciation that implementation is a many-faceted puzzle, or, as Neal just said to me, conundrum, and that we'll learn a lot from these guys about how that puzzle can be solved.
Both USAID and NIH were approached by researchers and others pointing out that there is some promise for chlorhexidine as an antiseptic to prevent both maternal and newborn infections. One of which was a trial in Nepal where an AID platform for research actually had been a place where NIH nested a trial showing promise of chlorhexidine. The trial demonstrated a 34% reduction in newborn mortality. The trials would have gone nowhere if we hadn't already concurrently been working on how do we deliver the product? What are the different mechanisms, public, private? How do we engage with industry? What would convince government? That's really the conundrum for us. How do we do this efficiently?
In Nepal, 63% of women give birth at home, mostly in unhygienic conditions, and 41% of babies had some substance, usually oil, ointment, turmeric, or ash, applied on their umbilical stump, which can lead to infections. 4% chlorhexidine, a broad-spectrum antiseptic, has been proven to be effective at preventing infection. Use of chlorhexidine for cord care was piloted in 2008. Based on the pilot results, the Ministry of Health and Population approved of nationwide scale-up of the program by integrating it with other ongoing government programs. As a part of Saving Lives at Birth, a grand challenge for development, USAID awarded JSI R&T a grant to implement the chlorhexidine Navi Care program at the national level.
And the chlorhexidine has been already included as a part of essential newborn care in the community-based newborn care packages, and it is in the process of inclusion of skilled birth attendant curriculum and pre-service curriculum, and we are hoping we could include that in the SPI and pre-service curriculum by end of 2013. We are using this tube, individual tube for the baby. Now we are trying to introduce new bottle for the hospital. And at the same time, you have seen in the like baby doll, I used as a counseling to the community. It was a whole big baby, but it was hard to carry in the hard to reach area. That's why we are modifying with the half baby, new half baby. At least we can fold it and transfer easily to the community.
The work that we're doing in Nigeria is heavily driven by evidence. You know, it's looking at the research, what's been published, but especially important is how do you translate what's in, how do you translate that when you sit down in front of a politician to convey the same story? I think that's one of the successes that has emerged from Sokoto State. Taking evidence from Lancet and so on and so forth and presenting it to a bureaucrat in a way that he's fired up and he takes that message to the farthest places. So what we have as a consequence is in Sokoto State, it's about 5 million people in the northwestern fringe of Nigeria. Approximately 96% of deliveries take place at home. As you know, you may know, Nigeria's maternal mortality rate is very high, in the 500s. Double that, and you have what you have for Sokoto State. So it gives you a sense of just the fragility and the potential tragedy that we have out there. Sokoto State government took the bull to the horns, and the thing that really excited them was that they could actually be a pathfinder for the country as a whole. And they relished that position, and they have invested their resources. And as we speak now, 56,000 doses of chlorhexidine are now in country. They've helped to train 2,400 community-based health workers. They've overseen the design of community-based distribution system.
There are different factors related to product profile that can affect the supply and demand of the product. For chlorhexidine, it's relatively simple. You have a gel product and then you have a liquid product. So those are the two main formulations, right? But you also might want to do a few little things to those. So you might consider, for example, the way you're presenting the product. You might want to present the product in a spray bottle, or you might want to present the product in a pre-moistened towelette that Steve really likes to talk about. Or you might want to add color, or you might want to add scent to the formulation. So each one of those things, as you think about it, have an impact on potentially user uptake or ease of distribution of the product or pricing of the product or even the regulatory pathway. And then the other piece that I just wanted to mention is about establishing an affordable and available supply of product. So, there are different ways of doing that. One way of doing that is through establishing local production at the country level. You could also have regional production. You could also have global supply. So for chlorhexidine for umbilical cord care, which is a relatively simple product to make, in fact, countries may feel like, oh, we can do this at the country level. This is easy. And in fact, countries may have the capability of doing that, and it will be fine. Some countries may feel like they can do it, although they might not necessarily have the ability to assure the quality of the product.
This is a very exciting period for us right now with chlorhexidine. There's probably at least a dozen countries that are either taking first steps in introducing chlorhexidine or actively discussing it. As many of you know, the Secretary General's Commission for Life-Saving Commodities for Women and Children's Health has prioritized chlorhexidine as one of its key commodities. We've heard about the experience in Nepal and Nigeria. The one other country that's moving ahead right now, this is Madagascar. Madagascar, like our Global Technical Working Group, it's a multi-partner effort with important roles being played by PSI and a social marketing project, by MCHIP Chipago, and by a JSI bilateral. We focus in the first stages on, well, how are we going to buy the chlorhexidine that we need for our formative work or for our piloting. But from very early on, we need to think about secure long-term funding arrangements at scale. So Leela mentioned that we're now at the stage in Nepal where the government is committing to buy all of the chlorhexidine that's going to be needed. And we're starting off very, very well in Sokoto, where the government from the very beginning is committed to purchasing the chlorhexidine. We also need robust supply chain. And if we have an existing supply chain that's reasonably good, then we can build on that and work with that. But if we don't have that to begin with, we need to assure that, we need to build that. We need to have service delivery strategies that take advantage of the existing channels. Finally, on an ongoing basis, like as a program is being implemented at scale, we need to have robust program performance management. And that means that we need to be monitoring key aspects of program performance, especially coverage. And we need to be equipping people kind of up and down the management chain to be using data that's coming from their monitoring to continually improve performance of the program. There are existing practices of applying something to the cord. So in Nepal, you heard about the application of mustard seed oil and other substances. Well, in Madagascar, there's a very common practice of applying alcohol to the cord stump, both for home deliveries as well as for health facility deliveries. So we're starting with an already existing feeling that you should be putting something on it. And it's important to take those existing practices into account and to build from there.
We have a strong imperative to promote facility-based care, especially facility-based delivery. There is still no substitute to it. And everything we're doing, even in terms of promoting the use of misoprostol at home, is expressly intended to ultimately, if the birth needs to take place away from the home, that we make that happen as quickly and as soon as possible. But there's still a number of factors that still compel women, sometimes by choice, but often not by choice, to have the baby at home. And our goal is to save the mother and the child as well.
I went to Nigeria twice to work with TCIP, and one was to participate in the UN Commission meeting at the same for the life-saving commodities. At the same time, we got opportunity to share on behalf of Chlorhexidine working group meeting, and we shared the Nepal experience.
It's great that, 50 countries, know about chlorhexidine from umbilical cord care, and maybe 50 countries have actually even attempted to introduce it at some level in a pilot phase. But if that's as far as it goes, it's really not going to have a huge impact on mortality. And what we really want to see is that. So what we ultimately need to look at is what are the coverage rates at a population-based level.
Chlorhexidine it's very cheap. Like, it can be as cheap as a few cents per newborn. We've got evidence that it's efficacious, and in high mortality settings where infection accounts for a large proportion of mortality, you can avert a significant proportion of newborn deaths by using chlorhexidine. It's easy to deliver, so even in weak health systems, there's potential for achieving high coverage.
Has to replace the traditional harmful practices.
I think we called it the best buy in newborn health that's available currently.
If you're serious about health activism, if you're not writing an editorial on chlorhexidine and newborn care, then you've missed the boat.